Hi, I'm Prakash Manoharan and I'm a consultant radiologist and nuclear medicine physician at the Christie. I'd like to thank Neuroendocrine Cancer UK for inviting me to give this talk about diagnostic in neuroendocrine neoplasm for the National Education Webinar Series. These are my disclosures. We start off looking at a number of general introduction themes. With regards to epidemiology of neuroendocrine neoplasm, the vast majority of tumors occur in the gastroenteropancreatic system, followed by the respiratory system, and the other sites of disease are quite rare. The incidence of neuroendocrine neoplasms is increasing year by year, as indicated by the graph below, and this affects nearly most sites of the body. The patient journey continues to be complicated. There is usually a delay in diagnosis with a number of wrong diagnoses that's been proposed when a patient presents to the clinical team, including Crohn's disease. The assessment and early referral to a neuroendocrine specialist clinic is recommended when the patient presents to a GP or a generalist. Molecular imaging and MRI are the backbone imaging modalities in the management of neuroendocrine neoplasms. At the Christie, we routinely perform IV contrast enhanced gallium dotatoc PET-CT and IV contrast enhanced liver MRI as a baseline in most patients. We're next going to look at the nomenclature in this disease process. There are many terms that are used interchangeably and possibly inaccurately in many different circumstances. And this misrepresentation can affect the understanding of the disease process and treatment options. It is also confusing for the medical teams and patients involved. Let's start with the nomenclature of describing this disease process. Neuroendocrine neoplasm encompasses neuroendocrine tumors and neuroendocrine carcinoma. The difference between neuroendocrine tumors and neuroendocrine carcinoma is not only the morphology, but also the Ki-67 proliferation index, as illustrated here. This is an example that's been utilized in pancreatic neuroendocrine neoplasms and is the model that we're working towards to try and describe this disease more consistently. Therefore, the nomenclature does matter with regards to the description of these tumors. Molecular radiotherapy involves the utilization of radioactive substances which are administered into the patient as a solution or emulsion of nanoparticles. Molecular radiotherapy is sometimes called radionuclear therapy, radioligand therapy, or nuclear medicine therapy. Radioligand therapy, or RLT, is a form of MRT, and peptide receptor radionuclide therapy, which is PRRT, is a form of RLT. For this talk, we will utilize the terminology RLT throughout. Theragnostic is a word that is a combination of therapy and diagnostics. Theragnostics, also sometimes known as Theranostics, is a treatment strategy that combines therapeutics with diagnostics. It associates both a diagnostic test that identifies patients most likely to be helped or harmed by a new medication and targeted drug therapy based on the test result. Now that we have been through a number of introductory slides and nomenclature, I'd like to now move on to describing theranostics in more detail and then looking at how this particular technology and technique is utilized to select patients for radioligand therapies. We start off with theragnostics. Theragnostics is underpinned by molecular imaging. Molecular imaging is aimed at the exploitation of specific molecules as the source of image contrast, which allows us to have early detection and characterization of disease, utilizing the patient's molecular signature prior to irreversible damage ideally. It also allows us to understand the underlying biology of disease processes better and hopefully leads us to have the ability to specifically select treatment options for targeted therapy. Essentially, the concept of diagnostics is underpinned by if you can see it, you can treat it, in which nuclear medicine plays a significant role. I'd like to take a little bit of time to explain to you what a radionuclide tracer is. A radionuclide tracer is a key aspect of nuclear medicine imaging, and it allows us to label radiotracers to specifically target tumors. In this particular case, with regards to radioligand therapy in neuroendocrine tumors, we want to target the somatostatin receptor in the cell wall of the tumor, and the ligand that is actually going to go to that particular target is called octreotide. Octreotide is a somatostatin analog, and that somatostatin analog is linked to the radiotracer by a linker called DOTA, and the radiotracer is then split into either a diagnostic radiotracer or a therapeutic radiotracer, and we need both of these to function and be positive in a patient before they can be considered for radioligand therapy. And essentially, by switching the diagnostic to therapeutic, we can actually target a patient's tumor with therapeutic radioligand therapies. A simplified way of looking at this is the diagnostic tracers are like a sprinter, quite light and very fast, and therefore we can actually picture them with a camera. And the therapeutic tracers or emissions are slightly heavier, and in the case of a beta particle, which are the particles being released by lutetium, they are more like a middleweight boxer, so there's a bit more of a power and strength around it. However, they probably will not be able to travel as far, and therefore not be able to be seen by many different diagnostic cameras. And with regards to alpha particles, it is probably more akin to a sumo wrestler, heavy, with a lot of strength and local deposition of radiation, but really doesn't travel that far. And this sort of depiction of the different radiotracers helps us understand how we can deposit energy and therapeutic intensity for the patient based on the different radioparticles. So what are the diagnostic radiotracers utilized in neuroendocrine neoplasm? We essentially utilize somatostatin receptor labeled particles which target somatostatin receptors 2, 1, and 5. And occasionally we also utilize fluorodeoxyglucose, which is essentially a glucose particle, to further characterize disease in patients with neuroendocrine neoplasm. So how can we go about identifying appropriate patients for radioligand therapy? We utilize the imaging modalities of PET and SPECT, and as you can see here, the PET scans demonstrate a high level of sensitivity with regarding to diagnostic accuracy in detecting tumors. However, the somatostatin receptor imaging utilizing SPECT is also pretty good and outperforms CT and MR in actually diagnosing patients. So in fact, we would advocate all G1 and G2 NET patients to have a somatostatin receptor imaging modality, either PET or SPECT. And please do not forget that the NET-1 study was underpinned by octreotide scan, which is a SPECT CT scan. And if patients demonstrate high uptake on a SPECT CT scan, we can then go ahead and treat these patients. In a small select group of patients who have either G2 or G3 morphological disease processes, we then can utilize FDG PET-CT to further characterize these patients or any patient who have an atypical clinical feature. Moving on to therapeutics, utilizing radioligand therapy. This image here demonstrates it quite well. The previously demonstrated radiotracer that has the radioisotope and the target ligand, in this case the somatostatin receptor, which is expressed more frequently in neuroendocrine neoplasms. By utilizing a radioligand therapy technique with a somatostatin receptor, and in this case lutetium, these cells are targeted by the particular radiotracer, and when these radiotracers actually embed and actually attach themselves to the target site, there is local release of radiation, therefore causing damage to the particular cell. These radionuclides that are used for therapeutics have many different characteristics, and a vast majority of them that are currently utilized have a therapeutic emission that is based around the beta particle. However, more recently, there's been a shift towards investigating and assessing radionuclides that emit alpha particles. So what is the difference between an alpha and beta particle? Apart from their emission, the amount of energy deposited per path length traveled, that's essentially what is designated as a linear energy transfer of an alpha particle, is approximately 400 times greater than that of electrons, which is a beta particle. This does not necessarily mean that alpha particles are better. It is just it deposits more energy, and in certain circumstances, in the future especially, this type of therapeutics is something that would be interested in trying to expand and investigate further. We will now move on to patient selection using the Theragnostic principle in managing the disease process. Just a quick recap. If we can see it, we can treat it. These are the basic principles of molecular imaging and therapy, or theragnostics. So the images on the left-hand side demonstrates a diagnostic radionuclide showing sites of disease involving the liver and lymph nodes and bone sites, also within the lungs. And the same patient then gets treated with a therapeutic radionuclide on the image on the right-hand side. And as you can see, there is a good mirror image of the sites of uptake on the diagnostic and the therapeutic radionuclides. Therefore, this patient would be appropriate for radioligand therapy, utilizing the Theragnostic principles. So again, if we can see it, we can treat it. Suitable patients for radioligand therapy in neuroendocrine neoplasms in the UK should ideally express somatostatin receptors with uptake that is similar to or higher than the liver. The patient should have inoperable disease with a life expectancy of at least 3 to 6 months, with a tumor that is either grade 1 or grade 2, and a tumor proliferation rate that is below 20%. Let's look at a number of cases together on how molecular imaging can be utilized in selecting the best treatment option for patients. We start off with case 1, who's a 60-year-old male patient with abnormal bowel symptoms, and this is the patient's PET scan. As you can see, this particular hotspot here is the site of the primary with 2 focal areas of further abnormal uptake adjacent to this. These are lymph node disease metastasis. So in this particular case, because of the slow presentation and early presentation, we think this disease is grade 1, which was eventually proven on the histology. This is a distal small bowel tumor. The liver at this particular stage is not involved in this particular scan. The patient was not functional, and the disease appears to have been indolent and slow growing. And there are future assessments that are required to see whether the patient needs systemic therapy. But for now, based on the current imaging, this patient was treated with radical curative surgery, and as it currently stands, he is still disease-free. Case number 2 is a patient who was 15 years old who presented with pain on the right side of the abdomen, which turned out to be a liver fuller tumor. This area was biopsied and revealed a grade 3 neuroendocrine tumor of unknown primary. The patient did not have any functional symptoms and demonstrated progressive disease. As you can see, the image here on the left-hand side is a gallium dotatox scan, which is another kind of PET scan looking at somatostatin receptor. What it demonstrates are focal areas of uptake within normal structures with no uptake within the tumor sites. However, the same patient then had an 18F-FDG scan, which is essentially the glucose scan, and as you can see, there are many different sites of disease involving the bones, the liver, and lymph node sites of disease. So this is a very typical characteristics of a grade 3 aggressive tumor. So this patient would not be suitable for radioligand therapy utilizing somatostatin receptors because really there's very little expression of somatostatin receptors. This patient was then treated with chemotherapy using cis-ETOP. So this particular case clearly demonstrates the significant utility of molecular imaging to try and categorize which patient would be suitable for for the different kind of therapies that are available. The next patient is a bit more typical of the kind of cases that we get. This patient presented with bilateral lower limb swelling. What we can see here is a site of disease involving small bowel, and this particular umbrella-like structure is essentially disease involving the IVC. There are also sites of disease in the liver. Biopsy of the liver lesions demonstrated a grade 2 well-differentiated small bowel neuroendocrine tumor, and the patient was functional and the disease was progressing, and we opted on balance to treat this patient with radioligand therapy. Why is that? There's really intense uptake of activity within the sites of tumor, and therefore this patient would be suitable for radioligand therapy. And that's exactly what we did. With the first dose, as you can see, there's matched uptake at the sites of disease. Within the second dose, you can see some of the areas actually demonstrating response to therapy. So this is really good result for that particular patient. And again, this particular patient was treated with radioligand therapy based on the imaging parameters. Case number 4 is a bit more complicated. It's a 35-year-old man with metastatic grade 3 well-differentiated neuroendocrine tumor of the pancreas with a higher Ki67. The patient had quite a number of previous lines of chemotherapy and was referred for PRRT or RLT because of intrahepatic progression, and we treated him on a compassionate basis, which is an off-license indication. So this patient actually turned up with a grade 3 well-differentiated tumor of the pancreas. It was not functional and it was progressive, and this is the extent of disease seen on the gallium PET, which is a somatostatin receptor scan, demonstrating quite extensive disease involving the bone marrow and quite extensively involving the liver. However, if you look at the liver between the CT scan and the PET scan, areas where there are clear regions of tumor, the uptake is quite heterogeneous, which is not a very good sign. However, the uptake was similar to or just slightly higher than the liver at the sites where there are heterogeneous uptake, and therefore we opted to treat this patient with radioligand therapy. And the patient only managed 2 cycles of therapy because after the 2 cycles of therapy, new sites of disease started occurring in the patient's abdomen, and this is due to the heterogeneity of uptake of the tracer, and therefore in patients where there's heterogeneous uptake, the role of radioligand therapy is still to be determined and might only have limited utility. As you can see in the follow-up scan, the patient had new sites of disease involving the nodal sites and also within the peritoneum, and this is after 2 cycles of radioligand therapy. So in this particular case, the imaging sort of hinted that there could be difficulties in treating this patient with radioligand therapy, but as this was a compassionate basis, we tried to salvage the patient with the therapy, but unfortunately it was not very useful. For the last few slides, I'd like to talk about clinical trials and alpha emitters. As many of you know, the NETTO-1 study established the role of radioligand therapy in neuroendocrine tumors, and this is currently the only randomized clinical trial study in neuroendocrine neoplasms utilizing radioligand therapies that has been licensed for the use in this patient group. There are a number of radioligand therapy clinical trials in the UK. The NETTO-2 trial utilizes somatostatin analogues as one arm, and the other arm is Lutathera in a population with G2, G3 well-differentiated morphology, and this is now completed recruitment and awaiting the accruement of all the results. COMPETE is the next trial utilizing everolimus and another form of octreotide-labeled therapy with lutetium. This particular group of patients expressed G1 and G2 grade tumors, and this now has completed recruitment and now awaiting events to have a full report in a number of years' time. The currently recruiting trial is called COMPOSE, and again utilizes the same lutetium labeled octreotide particle versus best standard of care in well-differentiated grade 2 and grade 3 tumors. All the above clinical trials utilize beta particle emission in radioligand therapy. There are a number of targeted alpha emitter or particle therapy as listed below. Various alpha emitting radioligand therapies are all in development stage and currently not available in the UK. I'm going to wrap up the current session with just a few more slides. So what does the MI data describe in our neuroendocrine neoplasm patients? As you can see, these two images demonstrate quite a complex distribution of disease in two different patients. It effectively demonstrates that in the real-world experience of human diseases, it is complex, it's multi-stage and multi-parametric. I'm now going to summarize my talk. Diagnostics is crucial in the management of neuroendocrine neoplasm patients. There's no versus in managing patients. Essentially, we need to utilize best evidence and best available technology and be consistent. Patients usually receive multiple therapies, and there is a need to identify subgroup of patients who would benefit most from each therapy, and that's where diagnostics is really crucial. And the message has to be that one size does not fit all. And optimal sequencing of therapeutics without missing the window of opportunity is a key concept in dealing with patients with neuroendocrine neoplasm. I'd like to acknowledge and thank the team at the Christie for some of the slides. Thank you.